Hello, hello everyone. Good afternoon.
Hello, can you hear me?
Hello, hello. Now we can start to check the technicians. We will start to check the audios and the voice of the guest. So, Miss Duong, can you hear me?
How are you?
Yes, I can hear you.
Okay, now we Mr. Lưu Trí Dũng, Mr. Lưu Trí Dũng, can you hear me? Hello, Peachy.
Yes, I can hear you. How about you? Can you hear me clear?
Okay.
Okay, thank you.
So, anh Tuyền will start to check the voice of the speaker first. You can check the voice and the strain rate of the speaker and strain later.
Okay, Mr. Sung, please set up me into a host.
Hello. Hello, everyone. Can you hear me?
Yeah, yes, I can hear you.
Okay, yes. Hello, Patrizia and Altino.
Hello, good morning.
Very nice to meet you. Yeah, I hope
Yeah,
you well.
my pleasure. Thank you for this invitation. It's a great pleasure. Thank you so much.
Yeah, we are very glad to invite you. Yes, and it is hoping you will enjoy with the CPD. Thank you.
The pleasure is mine.
Mọi người giúp bác Công test cái micro giúp rồi.
Vâng, xin hello everybody. Can you hear me?
Yeah, yes, I can. Thank you.
Okay. Yes.
Miss Fang and Jen, please check your mic.
Yes.
Good morning. Can you hear me?
Yes, I read you.
Okay. Thank you very much. I was trying to solve some microphone issues. So thank you once again for the kind invitation, and hope my internet connection helps during the webinar. But I would like to thank you once again for the kind invitation to be here today.
Yes. Okay. Thank you, Mr. Altino, and yeah, you try to get the best, the good internet is for your presentation. Yeah. Yeah. Thank you.
Mr. Trung. Hello, Mr. Trung.
Yes, I'm here.
Yes, what time will we start this session?
Yeah, we will start to showing the video now. Yes, and about 15 minutes later.
15 minutes later.
Yeah, yeah.
So because my member asked me in the program start with in the
14.
3:30. Okay. They now
2:14 p.m. Yeah, 2:45 p.m.
2:45. Oh, okay.
Yeah.
Okay.
Now we will starting to video for the Da Nang.
Okay, the promotion, right?
Yeah.
Okay.
Yeah.
Thank you.
Yeah. See you later. Okay.
See you.
Hello, Mitrin. Can you hear me?
Yes, okay, vâng. Thank you. Anh Trang đâu hả?
Hello, Mr. Quốc Anh. May I check your speak? Mr. Quốc Anh.
Okay, hello.
Tí bắt anh hơi nhỏ nè, bắt bằng lớn.
Nghe rõ chưa anh? Hello.
Okay, better.
Yeah, thank you.
Can I start now, Sir Leung? The string?
That's why a few minutes I waiting for where's Mr. Long.
Okay, just give me a cue.
Yeah.
Hello, Peachy. I didn't hear you.
Yes, hello po, President Locke.
Yes,
Happy New Year.
you hear me?
Yes, perfect. Yes.
Good morning, President. Thank you so much for this kind invitation. Morning.
And congratulations.
Thank you so much. It's my pleasure to see with you today. Thank you so much.
Everybody interested about you attend today. Everybody yes, in Asia.
Yeah.
Yes. Oh, I didn't see an Altino.
Yes, he's here, but I think needs to restart the computer, but in few minutes come back.
Yes. Yeah. Okay, you attend October in Dubai in ISRT Congress.
I don't know at this moment, but I'm working maybe on that. I needed to organize some commitment in parallel, but I think so.
We hope to in leader in Asia. We need to meet you, have a meeting with you, and how in collaboration from Asia and Europe.
Absolutely.
Yeah.
Will be a pleasure for me. When you want, completely available.
All the way welcome, all the congratulations. I will tell in Peachy and Fernando Koch, we are the and on president in Asia. Also, and I also tell in Czech we.
Yeah. But in the next few days, if you want, we can define a call with you so we can talk about everything.
Oh,
and
yes.
Also with Altino, so we can share some information, and happy to her as is possible to support.
Okay, now I'm going to not. Yeah, and 3 p.m. We still have 20 minutes. I want to introduce you Director Asia CPD in Bichiluna. Also say hi with her and Fernando Koch also. You Bichiluna, you talk something?
Yes, hello, madam. I'm very happy to meet you. Although this is first and online, I hope that I'll be able to have the chance in the future to meet you personally. Very much excited to be talking about progress regards CPD Asia and EFRS.
Thank you so much.
Welcome to CPD Asia.
Thank you.
Hello, Mr. Patrizia. I am Fernando from Macau. Welcome to join us. This is the first time we have from Europe. Because from Europe, the first time in Asia. So thank you very much to support us.
No, it's of course very my pleasure, and also it's an honor for me to start with this experience with you. So thank you so much to think the EFRS and myself in this case as current president, but it's a very pleasure. I hope in the next future to have possibility to collaborate with you also in other activities. So I'm very happy to stay here.
Sure, thank you.
Okay, I will put now we saw video. Introduce something. Yes, okay.
The Vietnam Association of Radiological Technologists, VART, invites you to the SEARC 12th Conference, Macau, Philippines, Vietnam 2nd. We are pleased to extend an invitation to you for the 12th SEARC and the 2nd Macau, Philippines, Vietnam Conference in Da Nang, Vietnam. Date, June 20th, 2026. Venue, Royal Lotus Convention Center, 128 Nguyen Van Thoi, Nguyen, Da Nang, Vietnam. For details, visit www.vart.vn or contact 84-9042343110/tridunk@gmail.com. We look forward to welcoming you.
Radiology is the home of ours. Radiology is home to the world. Uniform is the white coat of ours. Uniform is the angel white coat. This same home is ours. Is the global home. We share global home. It's home radiology. Radiology, shoulders by shoulders. Radiology, we stand no challenge. Radiology, we bring better life. Together we stand for our humankind. This same home is ours. Is the global home. We share global home. It's home radiology.
The Vietnam Association of Radiological Technologists, VART, invites you to the SEARC 12th Conference, Macau, Philippines, Vietnam 2nd. We are pleased to extend an invitation to you for the 12th SEARC and the 2nd Macau, Philippines, Vietnam Conference in Da Nang, Vietnam. Date, June 20th, 2026. Venue, Royal Lotus Convention Center, 128 Nguyen Van Thoi, Nguyen, Da Nang, Vietnam. For details, visit www.vart.vn or contact 84-9042343110/tridunk@gmail.com. We look forward to welcoming you.
Wow. Hello, everyone from Asia and to all our audiences around the world, especially our friends in Vietnam. This is CPD Asia, the online continuing professional development platform for Asian Radiologic Technology Societies, and hosting the 58th CPD Asia program. Our first in our 2026 series is the Vietnam Association of Radiologic Technologists, VART. I am Peachy Luna, CPD Secretary General, and your program host. We are live streaming on YouTube. You can search PARI, VART, or VT Healthcare Vietnam channel, so you can join us live or watch the replay anytime. So before we begin, let me extend our heartfelt appreciation and warmest welcome to all our presidents, our officers, and to our invited panelists who are joining us here. Good day to President Fernando Quoc of Macau Radiological Technologies Association.
Hello. Good afternoon, everyone.
We also have the President of Perhimpunan Radiographer Indonesia, Indonesian President Dr. Giek Subianto.
Hello, everybody. Good evening.
Yes, I think we have here attending for President Nang Tat Ming is the Vice President, President Nelson Juan Nelson.
Hello, nice to meet you. Thank you, VART, for hosting this event. Thank you.
Yes, we also have here President of Malaysian Society of Radiographers, President Sawal Mar Said.
Hello, everyone. Thank you for inviting us, and it's not too late to wish all of you a Happy New Year. Thank you.
Thank you, dear President. We also have President of Society of Radiological Technology Sri Lanka, President Vipalasena Gamage. Okay. And we also have our panelists who are joining here. Madam Chan Lai Kwan from Malaysia.
Hello, everybody. Wishing you Happy New Year 2026. Nice to meet everybody again.
We have here Sir Jerry Pedro Lay, the new chairman of the MRTA Macau.
Thank you, Peachy. Nice to meet you, everyone. And good afternoon to all the Vietnamese members and all our society's delegates. Good afternoon, everyone, and Happy New Year. Thank you.
Thank you, Chairman Lay. We have also received greetings from President of Singapore Society of Radiographers, President Chu, President Sophie Lee of Cambodian Association of Radiologic Technologists, from Indian Society of Radiologic Technologists, President Bagwat, and also Philippine Association of Radiologic Technologists, President Ruben Lorenzo, and President Chun Yuan Tu of Taiwan Association of Medical Radiation Technologists. So before we start, may I humbly request everyone to please open your camera for a very short photo opportunity. All right, smile, everyone. Okay, thank you. So thank you, everyone, and they will be joining us again later during the Q&A session. So for today's very interesting session, I would like to call in our moderator. He is Mr. Lu Tri Dung from the Department of Radiology of Da Nang in Vietnam, and also the Director of International Affairs of Vietnam Association of Radiologic Technologies, VART. Mr. Duong?
Thank you, Peachy Luna. Thank you, Peachy Luna, for your introduction. And good afternoon, President, panelists, lecturer, and all participants from Vietnam and around the world. My name is Lu Tri Dung, and today I'm very glad to be here as the moderator for this CPD. What special one CPD? So welcome all of you to the 1858 Asian CPDs hosted by Vietnam Association of Radiological Technologists, VART. And first of all, I'd like to invite the VART President, Mr. Thái Văn Lộc, to give the greeting. Please welcome Mr. Lộc.
Okay.
Please welcome Mr. Lộc for your greetings to everyone. Yes, please welcome.
Okay. Sorry, I have some problem. You hear me?
Yes, we all hear you.
Okay. Good morning, good afternoon, good evening, everyone. Congratulations. Dear Dr. Patrizia, President of EFRS. Mr. Altino, CEO EFRS. On today, very happy on President Asia leader. I didn't see in Czechia Vice President. I want to say welcome in Czechia Vice President Asia Australia ISRT. Dear all colleagues across Asia and Vietnam, on behalf of VART, today the 10th, the AI era and global connectivity very important. AI concepts, not just theory, a vital partner in medical imaging, but connectivity. AI is the tool. Connectivity is very strength, very important. Today, Vietnamese experts topic, we introduce for you how we get a profit. We get a profit. Acute stroke, AI, time in brain. We use the AI in acute stroke, very important. The second, we introduce you Professor Cong. How we get the profit? Tuberculosis screening, very important. Now we start DN tuberculosis in Vietnam. How profits AI and strategic vision, very important. I hope from today, Asia and Europe predict how for tailoring education and research. We move to standardization, moving toward and unified global standard for radiographer. I hope so from today, we more collaboration Asia and Europe. I have a message for the young generation. Now, AI era, we get to skill, master the digital the mindsets. And now you action, discuss, and building your network. You control the AI future and near future. Okay. Thank you so much. Thank you, organize. Thank you, speaker. Thank you, sponsor. I hope good health, success, and fruitful session. Thank you very much. Thank you very much.
Yes, thank you, Mr. Lộc, for your speech. And so we will go to the seminar. And following the themes of this series, the AI eras and global connectivities, I'm very honored to introduce two senior lecturers from Vietnam, combined with two senior speakers from Europe. So that is the president, together with CEO of the European Federation of Radiographer Societies, EFRS. So we are so excited, waiting for your sharing, and hopefully you all will get valuable insights in this topic. So we are looking forward to your discussion and your question in the Q&A session. Thank you. And for the start, please welcome the first lecturers, Medical Doctor Nguyen Quoc. He is a radiologist from Cunha International Services General Hospital in Vietnam. He has more experience in advanced imaging techniques and also specialized in delivering accurate diagnosis using modalities such as MRI, CT, and X-rays. His expertise encompasses a wide range, including neurology, oncology, cardiac imaging, and also vascular disease. He also the lead investigator and research assistant of Phan Ngọc Thạch University of Medicine and Cunha International Services General Hospital. In addition, he is a member in the regional committees of Asia, the Radiological Society of North America, and the member in the North American Society for Cardiovascular Imaging, and also the member of the American Society of Neuroradiology. So he's the title for his presentation is Time in Brain, Radiologist, Frontline, and AI Application in Acute Stroke Decision Making. Please welcome Dr. Quoc. Please welcome Dr. Quoc for the first. Yeah.
Hello, everyone. Do you hear me?
Yes.
Yeah.
Yeah.
Yes, well, thank you for your invitation and introduction. And today it's my honor to face here in the 58th, the CPD of Asian Radiological Technologists Societies. And today I will share about the topic that is the time brain, radiology, frontlines, and AI application in acute stroke decision making. And no information to disclose. We will go through some content about CT, MRI, AI, and DSA in acute stroke, something about stroke mimics and big falls. And as we know, global burden of stroke stands as second cause of death and the third leading cause of death and disability. And every year, there are about 12 million new strokes, and we can see the map. The proportion of stroke patients is highest in Asia. So that's why make the right decision making is very important. And there are two types of stroke: ischemic stroke due to the occlusion, and hemorrhagic stroke due to a rupture of the vessel. The term midbrain is the most important slogan in the stroke patient, with some typical symptoms including face throbbing, arm weakness, speech difficulties, and T is very important for the time to call emergency. And then I show you the flowchart in the emergent process for the suspected stroke patient. After admitted to the emergency department, the clinical doctor and the team will have under 15 minutes for examination and giving some indication, including blood stat or and radiology indication. And the patient will move to the radiology department with the CT room or MRI room under 30 minutes. And we can get all the practice stuff, the imaging, with under 30 minutes and get the decision making about RCBA or DSA. And after that, if the patient had the intervention is indicated, the patient will be transferred to the DSA unit with under 45 minutes. And so we can see the radiology stands as the gatekeeper of treatment decisions for RTBA, EVT, or ICU. And non-contrast CT is a traditional first-line imaging because of widespread availability, non-invasiveness, and safety with the shock scan time. And the traditional process for stroke patient, at first the non-contrast CT to rule out the hemorrhage or detect some early changing at the brain tumor. And in the second phase, with the contrast agent, CTA will be added in our CTB and CTV. But in non-contrast CT, we have some signature signs such as hyperdense artery size, gray matter, white matter differentiation, or hypodensity and the mark is fast. With a patient with under 4 hours, the percentage of detection is just around 16 to 34%, and under 6 hours, it's a 30 to 50% is close. And with this image, I want to focus you remind about the CVST. This is the hypodense in the brain. Many people can miss this lesson. And about contrast CT, this minimal invasive study to identify the stenosis, occlusion of the vessel, and find the reason such as aneurysm and other vascular abnormalities. And CT angiography can be performed a single or multi-phase, and CT perfusion can assist in identifying inner ischemic penumbra. And at present, we have many advanced machines, such as on the photon counting CT, will have to improve the quality imaging in non-contrast enhancement, evaluating lumen intrastent, decrease artifact by sleep, and with the scan mode with the dual source, the dynamic angle, it will be helpful in some specific situation. The new process in the photon counting CT for a stroke patient. At first, with the non-contrast CT, it is the same with the traditional, but in the contrast enhancement phase, the CTB will be added prior the CTA, and total time for this process it just takes 3 to 5 minutes. And then we can see in the left side is the imaging from the photon counting CT that radiologists can detect the early changing easily and maybe faster. With the CTB, after scanning, the machine will calculate all the characteristics from the report automatically. And with some case, we had the tool in the imprint, such as stenting or scoid patient screening after 1 year stenting and coils in the aneurysm treatment. And now we can see no artifact surrounding the stent and coil. Thanks to that, we can evaluate the brain parenchyma surrounding the tool clearly. And how about CT dynamic angle? It's available in all the machine with the dual source to perform a dynamic vessel evaluation in some cases of abnormal the vessel system. Vascular malformation, or if in some case evaluation of tumor vascularization. And now we can see the radiologist and the clinical doctor can detect and evaluate the artery system or the vein symptom in the one series after scanning. And move on the MRI in the acute stroke. We just need some basic sequences from diffusion, the 3D, SWI, T1, T2, and FLAP to make over 95% for the decision making. And diffusion, DWI is the most sensitive diagnostic imaging with the sensitivity and specificity ranges from 85 to 100%, and they must focus and remind a number about around 7% imaging of stroke patients with a negative on DWI, and the combination of diffusion and perfusion will increase the sensitivity up to 90%, 97%. And we had some difficult case. And this is the subtotal lesson with a 55-year-old man in the second hour with the left side hemiplegia. And now we can see in the artery, we can see this is the occlusion of the right vertebral artery. And when we check again many times on the WI, we can see this minimal subtotal lesson about retrostatic diffusion. Thanks to MRI, the patient was treated by RTBA with a good outcome. At the next phase, after we identifying about ischemic stroke or hemorrhage stroke, we need to know about the artery system. The third 3D can identify about where either occlusion of the small vessel or the large vessel in hemorrhage stroke with the aneurysm. We can see that where is the aneurysm or AVM, AVF, and screening and following of after treatment. We need to set up some characteristics in the protocol, especially in slide thickness. With the MRI free Tesla, 0.3 to 0.6 millimeter is recommended, and will return from C4 to C5 or to over colosum, and it can come really fast, 6 minutes, just 6 minutes. And why we need the large region? This for this patient, this 75-year-old man with history trauma brain injury, and he was admitted to the emergency department with some symptom similar to stroke. And thanks to the large region, we can detect. This is the setting of ICA where we can get the right decision making and the right treatment. In stroke, we can easily detect where is the occlusion of small vessel or the large vessel to get the trajectory in treatment. Or in some case, with the hemorrhage, especially subarachnoid hemorrhage, with the slide thickness just 0.3 to 0.6 millimeter, we can detect the aneurysm with diameter under 1.5 millimeter, and some case with AVM and AVF. And after we get information about this is how the types of stroke artery system, and we need SWI to identify some feature before getting the right treatment. And the main role of SWI or T2 prayer the identification of small amounts of hemorrhage, blood products, or calcium. But in ischemic stroke, there are some features really important, such as hemorrhage transformation. This is the contraindication in it for any defibrillator, such as TBA or EVT contraindication. And how about microbleeding of bronchial size? About microbleeding, following many documents, is not be a contraindication, but bronchiolitis maybe not be a safe choice for a stroke patient with the detection of microbleeding on SWI. And about thrombosis size, were detected is 76% in all, and it not differ between 1.5 Tesla and 3 Tesla. Thus, for instance, we had a case, the difficult case, the 54-year-old man. He was admitted in the emergency department at the 5th hours with the water bleacher and decreased consciousness. And after scanning, we can see the retrostatic diffusion on bilateral thalamus and on the artery system, the occlusion of the right BCA. And when we check again in the SWI many times, we can see the specific bond with the hypointensity. This is suggest for the thrombus, and the patient will move to the cath lab for thrombectomy method. And 8 hours after thrombectomy, with the good outcome in this patient. And T1, T2, and flare, they will help the radiologist and clinical doctor to get the stage of stroke. But the most critical note in here, the clinical examination and ask about history is the most important. With ischemic stroke, T2 and flare usually used for the identify the stage and inherent shock T2 and T1. So with only some basic sequences from diffusion to 3D, SWI, T1, T2, and flare, we can get the over 95% for decision making with some advanced MRIs in 3 Tesla MRI. The scan time is just 13 to 15 minutes. And MRI perfusion is only indicated in some specific situation at the time when the treatment decision based upon this measurement may affect outcomes significantly. And the imaging after scanning with perfusion, the radiologist can get the series, and radiologist can resolve and tour out the station to get results. I can show them to get any result. But it will take a lot of time. So that's why AI can have the radiologist here. And AI is a computer algorithm, and that can answer some medical questions such as detection, diagnosis, prognosis, therapy responses. And there are 3 types of AI used. At first, AI used an add by radiologist. The second, AI used a primary reader. And the third, the autonomous AI. And AI embed the imaging life cycle. AI can embed to all the steps of the process, from the test selection, protocol, triad, scan, report, and communicate. So in stroke, where it fits in the workflow, we can input the data about clinical data, needs, onset time, non-contrast CT, CTA, CTB, and with the AI engine, with the deep learning and machine learning, call the function for detection, quantification, prediction, and we can get the output about rapid triad orders, automatic aspects, and perfusion, and treatment support. So the key message here, AI can support faster decision, but clinical and imaging correlation remains essential. And about with AI support, we can trial faster, standardize interpretation, and make earlier treatment decision, often moving from NCCT trade to the perfusion first, and the rapid CTA confirmation with the immediate team notification. And the clinical impact is simple: shorter to imaging time, less interpretation variability, and faster RTBA EVT decision. And in MRI is so there's many application in MRI, but the clinical impact also improving accuracy, reducing stroke mimic misclassification, and support faster trial to EVT or medical therapy. And now this is the instance for us, the use of convolutional neural network to perform the super resolution. We can see the faster 55% of the scan time, and with the deep learning support, we can get the new series imaging that enough quality for the radiologist to read the result. Or see another case with only 10% of those. After using AI application, it also makes the new series that also enough in quality for any radiologist to make the result. And there are multiple AI vendors in drug imaging across both CT and MRI. One of the most impactful and widely adapted applications is perfusion analysis. But that I want to talk in this slide. I want to highlight the most updated concept about EVT treatment window can be extended up to 24 hours in selected patient. And in real-world practice, that means we often move fast and send the patient to the DSA cath lab and without perfusion imaging. So the indication is just for some specific case and some difficult case. For example, we had the case of 57 years old woman, and at the 6th hour with the right side hemiplegia, and we can see on the DWI and ADC, the collection is small, but on the artery system, the occlusion of the left ICA. After gathering to discuss about this case, is not appropriate between the parenchymal lesion and the occlusion of the ICA. So we decided to make the next step with the perfusion. And an hour after the first DWI, we can see the volume of lesion was increased. And after using Brigging AI, the mismatch volume over 200 milliliter. And thanks to that, the patient we moved to cath lab. And because in this case, we had two options on the first diffusion imaging. The first idea, the patient had to get the acute occlusion suddenly, or acute occlusion based on the chronic severe stenosis. It's thanks to the imaging from rabbit, we can identify the acute occlusion suddenly, and the patient we move to cath lab for treatment. And so this does summarize about the key clinical roles of AI in drug across 4 areas: in detection and trial, imaging, quantification, treatment, selection, and outcome prediction. And this AI in drug is the roles. This stands a role in treatment. And at our hospital, we are working to standardize clinical workflow and maximize the use of advanced technologies, so we can get the golden hour acute drug very high. This all the latest update from our hospital data. It's just 13% from 2019 to 25% in 2025 on golden hour for acute drug, with many documents in the world that announced this number under 5%, and some drug central is around 10%. And last but not least, but I will talk about something about stroke mimics, and this is very important. Stroke mimics, the condition that can clinically resemble acute stroke and lead to over-treatment or delay. And why it matters? The mimics can trigger the stroke cord activation or risk of unnecessary thrombolysis, or true stroke can also be missed. So there are a wide range of regions for the stroke mimics, especially in the metabolic and thoracic or vascular mimic. So the clinical doctor must be checked. We check in the patient with a local condition, such as history of fluctuating symptoms. and non-territory pattern. With the CVSD, many people, many radiologists and clinical doctors can miss this lesson, and this lesson is really critical. With some cases with suspected imaging such as edema in the bilateral in thalamus, and the region we must focus on all the vein system. The case time is just around 5 minutes to 7 minutes. For example, the case is a 4 years old boy admission with the vertiplature and decreased consciousness. In this case, after scanning barometer, we can see the edema in bilateral thalamus and MRV, the absent signal in the straight vein and the gallant vein. After the patient, we move to the cath lab for lobotomy of the venous. Or another case, which is a 44 years old man with the headache, only headache. After scanning, we can see the retrostatic diffusion on DWI in both sides, right side, left side, on both sides of cerebellum. But when we check the artery, is normal. The artery system is normal. So this is just for the 3 territory side, and we need to find the reason. Maybe is it malignancy or cardioembolic stroke. And after that, we decided to make the whole body scan, CT for this patient to find the tumor, and this is lung cancer with metastasis. And 3 territory side in malignancy, we need to remind them. Sensitivity is low, just 23%, but specificity really high, 96%. And I summarize the most common interpretation pitfalls across acute stroke imaging pathway from NCCT, CTA, CTB, and MRI, especially in the AI eyebrow. And we can see the AI caution. We need to avoid the automation bias and always validate our work with the clinical system and vascular territory logic. And we move to the case with the diffusion artifacts. I remember this case, really, this young patient with just light headache. And after scanning, we see the abnormal signal in the left cerebellum. This is the hyperintensity on DWI and hypointensity on ADC. But after gathering to discuss about this case, it's not appropriate between the clinical system and the imaging. So we decided to repeat the diffusion scan with the edit about some characteristics on FOV and matrix we increased. And after the second scanning, the imaging is normal. So that's with this case, I want to talk, we must be careful with our characteristic. This is another case with a similar situation. And in conclusion, the time mid-brain but accurate imaging tried the right treatment, but choosing CT or MRI is depending on clinical examination and facility available at the hospital. And remember, with ordinary process, the CT first, the CT fast, and SCT rule out the hemorrhage, and MRI can add the confidence and AI workflow. The AI can support this decision making, but it's not replacement. And beware, mimic and visual is really important, and fast, accurate, and teamwork, we can make the best outcome for our patient. And as our hospital, we fully embrace the principle that time mid-brain, we have optimized every step to a stroke pathway from the pre-hospital access to the imaging, treatment, and post-discharge follow-up. For instance, beside the ambulance, we prepare a speedboat because in the Mekong Delta, there are many rivers and many small branches river. We need to prepare it to take the patient to the hospital as fast as possible. And here, I would like to invite all of you to Stroke Interventional School 2026 at Contour City that will be held from 16 to 18 July. And thank you for your attention. I'm Dr. Quoc, and as a member in RSNA Regional Committee of Asia and Oceania, I want to connect with all of you because we need to shape the future of radiology in our region, and we can gather to strengthen the radiology field in our region. And thank you.
Don't hear Mr. Dung.
Okay, I'm here.
Yes, now we're here.
Yeah, okay. And so we compile combination of advanced CT, MRI, and AI. We will create a lightning fast and acute analysis process because the time is brand. So thank you again for Dr. Quoc for your presentation. And now please come into the second lecturers. We are very honored to welcome Mr. Altino Cunha, the CEO of the European Federation of Radiographer Societies. We're sharing about EFRS vision, Brigging education, research, and practice, a model of the future. Please welcome Mr. Altino.
Thank you very much for the kind introduction. Can you hear me? Yep. Okay. Apologies, as I'm experiencing some internet troubles. We had a storm overnight, but I think that I managed to sort all the internet issues. So I will share my screen now. And once again, I would like to thank the kind invitation. It's a great pleasure for me to be here today, sharing alongside with our president, Dr. Patrizia Cornacchione, the vision of the EFRS for the profession. Can you see my screen now?
Yes.
Yes. Okay. So as I was saying, we are here today to share at least the vision of the EFRS, and the EFRS, as you will see quite a couple of slides ahead, who we are. But first of all, I would like to make some disclosures. So apart from being EFRS CEO, I'm still also a clinical radiographer working in a medical imaging department in a small hospital in Portugal. So this is the outline of my presentation. Who are we, the EFRS vision, and our future, of course, and then I will hand over to Dr. Cornacchione to proceed with some specific topics about our vision and about research embedded in the education and clinical practice as well. So for you to have an idea, and thank you for all our attendees who are here today, learning a little bit about the EFRS. So the role of the EFRS, the European Federation of Radiographer Societies, is to represent, promote, and develop the profession of radiography within the whole range of the three branches: medical imaging, also known as radiology, nuclear medicine, and radiotherapy, and moreover, all that everything that is directly or indirectly related or beneficial to this role. Our community is spread across 40 countries. Right now, officially, we are implemented in 40 countries, not only in Europe, but also Egypt, Israel, Palestine, and United Arab Emirates. And we are composed of two kinds of organizations. So national societies and professional bodies, those who actually represent and act towards the development of the profession. But this mission of the EFRS couldn't be achieved, or our goal couldn't be met without the crucial support of universities. And that's why we usually say that we are pretty much one of a kind organization, at least in Europe, because we congregate national societies and educations under the same umbrella. And we are composed, as you can see here, currently we have 49 national societies and professional bodies and 52 universities, sorry. Basically, the EFRS management is, of course, has lots of more people rather than the 8 that are here mentioned in this slide. We have lots of committees, lots of working groups, lots of projects, task force. So I kindly invite you to visit our website, and you will be able to see all the EFRS management members. But I would like to draw your attention at least to the executive board, which is led by Dr. Cornacchione, but we also have a vice president and 5 board members coming from different countries within our community, which is something that we are proud of. We have this geo and gender diversity, which we believe is beneficial for the federation, but also beneficial for the profession. And my role as CEO is to support the board and always act on behalf of the board. This is something important to mention. In terms of the EFRS vision, and we also once again kindly invite you to read this document, which is available in our website, is the Radiographer Education, Research and Practice. This is the white paper and the vision of the EFRS for the future of the profession, because we believe that advancing radiographer-led research is crucial to ensuring evidence-based practice, which is something that we are very, very keen. Enhancing, of course, patient care. Patients are always at the heart of our work. It's one of our mottos. And of course, strengthening the professional role within the healthcare system, working alongside, collaborating with other professions, as we have seen here today with medical doctors, medical physicists, radiologists, nuclear medicine specialists, radiation oncologists, and others, nurses, other healthcare professionals. We should collaborate with them at all time. Of course, the EFRS is committed to fostering a research culture, and Dr. Cornacchione will also enhance this in her brilliant presentation by supporting collaborations, as I said, encouraging academic and clinical research, as I will speak a little bit more later on the presentation, and always advocating for radiographers' involvement in multidisciplinary research initiatives. Through this strategic approach, the EFRS aims to drive innovation, to contribute to policy development, and the previous speaker mentioned brilliant presentation, by the way, thank you very much, mentioned the use of AI and all the technologies that we have now available to put in favor of the patient care. And we also need to contribute to these policies with regards to these new technologies, and of course elevate the professional recognitions of radiographers across Europe, but also across the world, together with other stakeholders in other parts of the world. This is very important, and we believe that radiographers or radiological technologists, as probably this is the profession is more known in Southern Asia, we believe that both clinical and non-clinical roles should be one of the aims for radiographers, for the profession, is to develop clinical and non-clinical roles as part of the profession. So our main target, as I said, and our main mission is to strengthening education, research, and practice to enhance patient care. As I've mentioned before, this is one of our mottos, patients at the heart of our work, and this is how we see the profession and how we see the healthcare system. But for this, we need to harmonize. We need to be in a very good balance between education, practice, and research. And why this is important? Because even if we look to Europe, just for Europe, we see that we have different programs offered. We have medical imaging only, radiotherapy only, nuclear medicine only, medical imaging, including radiology and nuclear medicine. We have the three combined, and we have other programs. And we also have different overall durations of the programs, of the education programs. And also we have different European credit transfer systems allocated to the programs. So in Europe, we are still working on harmonizing this, and this is why we believe that as professional society or as an organization, we need to harmonize, because harmonizing is crucial to promote a common standard. And you can also see the results of these surveys in our website. And why this is important. As EFRS, we believe this is important because we need to have, as profession, we need to have consistency in professional standards. We need to also facilitate the workforce mobility, not only from Europe to from Europe to other regions, but from other regions to Europe, and also, of course, within Europe. And we also need to have this harmonization to support lifelong learning and career progression, as we believe these three topics are very, very well combined, and they are one of the supports to this professional harmonization. And bringing us to our future, and as my presentation is moving forward, we believe as EFRS, and this is a statement that is included in our EFRS white paper on the future of the profession, is that radiographers' contributions to medical imaging, nuclear medicine, and radiotherapy are limited only by their own expectations and ambitions. Of course, we as profession need to be ambitious in terms of developing our own scope of practice, standards of practice, our contribution to the healthcare system. But of course, we need to have in mind that the legal framework plays an important role as well. So law in the country in which they are in this case, we radiographers are practicing, is also something that we need to have in mind, because we don't want to step in nobody's toes. We just want to develop our profession and add value to the healthcare system. And we are proud to announce that this joint vision is not, as the name says, is not our only EFRS vision. It's a joint vision, and joint vision means this is a vision shared by the International Society of Radiographers and Radiological Technologists, the ISRT, but also in our fellow European stakeholders, for radiologists, for nuclear medicine specialists, for radiation oncologists, and also for medical physicists, but also for ERCA and for IAEA, which is very, very something that we are proud of, that we see so many worldwide stakeholders to share this vision for the future of our profession. So bringing to the document itself, to the three pillars that we believe support the development of the profession, and those are education, research, and practice, as I believe I've mentioned earlier in the presentation, and I will go rapidly through each of these pillars and before handing over to Dr. Cornacchione. So in terms of education, and please keep in mind that all the pillars are linked. We can't isolate any of the pillars. They work together as an equilibrium, as a balance to the development of the profession. In terms of education, of course, lifelong learning. We believe that the bachelor degree provides radiographers with the tools to start learning, and the learning does not end as soon as we graduate. It's a long life learning. We also need to, from time to time, or every time the world changes, which is pretty much every day, we need to also train our colleagues. Our radiographers need to be trained in the integration of emerging technologies, because we see that emerging technologies are everywhere, and they arise pretty much every day. We need to have a collaborative curriculum development. We need to work, as I've mentioned before, professional societies, academic institutions, but also other stakeholders representing other professions. We need to emphasize the science and safety, especially radiation protection, radiation safety, and moreover, patient safety. And we also need to educate radiographers on research and leadership skills. This is very important. And this is one of our main statements. We believe, as EFRS, that a radiographer should graduate at EQF level 6, bachelor degree level, meaning that we are, as professionals, ready to face the healthcare system pretty much better prepared to face the healthcare system. Moving to research, and once again, all pillars linked. Keep that in mind, please. We believe that we should integrate research in clinical practice. So research is not limited to academic institutions. We believe that also clinical radiographers have a major role in research. We need to once again collaborate cross disciplines with radiologists, radiation oncologists, nuclear medicine physicists, nurses, medical physicists, biomedical engineers, all disciplines. But we need to keep in mind that the central point of research should be the patient. We need to develop the profession. We need to research more. We need to integrate research more in clinical practice, always having in mind that the patient is the central point of the healthcare system. Once again, focus on emerging technologies, and we have seen from the previous speaker that emerging technologies, AI, but not only, new sequences in MR, new protocols for CT. And so we see that emerging technologies are always present, and of course support for doctoral level education. We believe that not only bachelor degree, master degree, but doctoral degree education is important, as we need to move forward in the knowledge level and skills level for radiographers as well. And that's why we believe in that, and that's why we have launched two different initiatives within the EFRS, which is the EFRS Patient-Centered Care Awards and Research Awards. Both they have different targets, but mainly they have one single common point, which is develop research, one more in terms of one more focused in terms of patient-centered care, but the other one is more into research, but both are connected as we need to develop the role of radiographers in research and in advancing the profession. And then we have our official journal, the Radiographic Journal, which is, as I said, our official journal, and we promote and we encourage people to submit articles and to publish their research in our official journal. And of course, our official Congress, which this year will be from 4th of March till 8th of March in Vienna. So European Congress of Radiology, organized by the European Society of Radiology, is also our official Congress. And curiously, the theme for this year is Rays of Knowledge, which we believe represents pretty much and very well the vision of the EFRS for the profession. So knowledge is one of the major topics of our profession and of our vision. We need to develop this knowledge, but always keeping in mind that we need to put this knowledge in favor to the patients and to the healthcare system. And last but not the least, the practice. Practice plays an important role. I would like to remind you that, for example, for Europe, 120,000 radiographers are in the clinical practice, meaning that, of course, and also EFRS as a professional society, we need to have a major look, an important look to clinical practice, to the clinical radiographers, as we believe also they play an important role, and that's why we believe this is a statement that we couldn't miss in our vision. So once again, patient-centered care in practice. So patients at the heart of our work. Safety and protection. We believe that radiographers can be and will be the gatekeepers of safety and protection, not only for patients, but also for other professions. So occupational safety and protection, we believe that we will be, alongside with other colleagues, of course, but we will be the gatekeepers of safety and protection. Once again, interprofessional collaboration. We can do anything by ourselves. We need to work closely with other professions and collaboratively with them. And we also believe that advanced and specialist roles in practice are the future of our profession. Not everyone will become advanced practitioner or specialist or will have an extended role, but we believe that some of us will have those roles, of course, based on lifelong learning, on academic development, on education and training, but we believe that also the future will bring us the opportunity to have these roles. And of course, CPD, as we are doing here today, is very, very important, and we can't overlook CPD, as this will lead. This will take us to the place that we believe we should be in the future. So, but just to this picture, just to remind you that patient is the center of our healthcare system and should be always in our minds when developing the profession and when namely in clinical practice, where we meet patients every day, every hour, every minute, every second. So as a conclusion, we believe that the profession will be built on the three pillars: education, research, and practice. And thank you very much. And I hope you have managed to understand my speech and my presentation. Happy to take questions or comments now or at the end.
Don't hear you.
Hello.
Yes.
Okay. Thank you, Mr. Altino Cunha, for your very excited for introduction about EFRS videos. Now we know about the Europe technologies, imagine to work and education, and also many things you sharing. And now we will come into the second speaker. I would like to introduce Dr. Patrizia Cornacchione with the same title. We will see another perspective about the EFRS from the Europe now. So please welcome Dr. Patrizia. And please note, you all can use the Q&A box to ask questions, and we will just send to the speaker and lecturers after. Thank you. And then please welcome Dr. Patrizia.
Thank you very much, and thank you again for this kind invitation. It's a very great pleasure for us as EFRS, but for myself also to be here and to share with you this experience and this opportunity. As EFRS is our first time with you, so this is an honor for me and to represent radiographers around Europe, and not only also in this important event. So thank you so much for this invitation and this opportunity. Yes, I think the same title as Altino said in the previous presentation, but it's important for me to underline some points that I will share with you to understand together the importance that we have regarding our knowledge, our skills, and the possibility to improve new strategy and skills for the future to improve our professional profile. This is my disclosures and who I am. This is some information regarding my background. In particular, I started my clinical experience in radiotherapy and brachytherapy field. At this moment, lead radiographers in medical physics and radioprotection at Policlinico University in Rome, Agostino Gemelli, and also assistant professor and senior lecturer in Università Cattolica del Sacro Cuore, always in Rome. And obviously, not only president for radiographers in radiotherapy in Italy, but always with great pleasure, also currently president of the European Federation of Radiographer Societies. And I will start again with our specific aim that we have in the EFRS to underline that the rule of the European Federation is promote and develop the profession of radiography in all parts of our profile is possible to work. So in medical imaging, nuclear medicine, and obviously radiotherapy. In this slide, it's possible to see how is possible to also to define a very complex management inside, but we are happy not only to have a political part to guide the profession, but also two important parts. First of all, the educational wing management team, because this is our important area that manage the university and the training program in the university, when it's possible to guide in different strategies to improve our role also during the training program in the university, but also very important to have different committees that help us to understand our issues, to understand our needs, and to define the new strategies to improve our skills and our knowledge for the next future, step by step, that we see new innovation in our profile. And we have in particular the Medical Imaging Committee, Radiotherapy, Nuclear Medicine, Research Committee, and CPD. Based on this important management that we have, I define in three important points. It is my presentation. First of all, why collaboration matters, but also how the education maybe is the key to advance our professional role, and to understand how the technical innovation can improve and join the expertise. So first of all, why collaboration matters. This is a very important point, also in my specific term. In my specific objectives, when I started my experience as president for the EFRS, I knew that the word collaboration maybe is easy, is simple, but the concept of collaboration sometimes is not easy. For this reason, in my idea, but with the very great support from the executive board of the EFRS, we are working to understand the best way to collaborate with other professionals, with caregivers, stakeholders, everyone that is important for us to collaborate and to define the new strategy, to knowledge everyone together to improve our activity, especially in the complexity of modern healthcare, because we need to share responsibility for innovation and especially for patient care. For this reason, in my idea, we need to improve this collaboration in 3 specific fields. First of all, with the profession, because we need to understand our needs, to understand our knowledge, and to decide the best way to improve step by step our activities, but also especially with other professions. So in this case, the collaboration, interprofessional collaboration, but obviously also with the patients. So first of all, with the profession, because we need to sharing knowledge, education also between us. And this is an image that is possible to see again our management, so not always easy because it's complexity to understand the difference in different areas that we have, not only research, not only clinical part, not only academia. So we need to understand the best way to collect our knowledge, to improve our skills together. But this is the way, because it is important to improve this collaboration, to drive the innovation and research for our profile, to improve especially quality and safety for the patients, and to promote, obviously, the evidence-based practice. But this is a very important task also when we need to collaborate with other professionals. As I said, also Altino in the previous presentation, is very important to understand the best way, because if we have more knowledge, more possibility to understand the picture with other professionals, maybe together we can improve better the different way that is impossible to have more quality and safety, especially in premise for the patients. And this is important because we can strengthen the resilience. We are also to improve our possibility to have always at the center of our activity the patients. And it is important also to improve in this way the soft skills, because it's important, first of all, also to improve our knowledge about communication and good relationship with the professional, but especially with the patients. And when we can talk together, different professionals, before, during the procedure with the patients, is so better to help to support the patients during the procedure. So together we can need to understand the best way to go in this aim. And this is an important experience that we have with cardiovascular society, radiology societies. We hope in the next few weeks to have an important document that will be shared with everyone, because we are working on a document that defines the importance to improve the education, to improve our knowledge, because it's important to work together, especially in this year when the innovation and AI is very important to understand, to knowledge, to learn, and to use together to serve the patients. This is an important article that underline from the part of the cardiovascular radiologists, because underline this important paper that we need maybe a dedicated and specific training as radiographers to support the different procedures, to support the different needs that we have during during important procedures, in this case in cardiovascular area, but it's important also understand in this article that is important also from radiologists to have a very trained radiographers to work together to work better for the patients. And why is important? Not only in cardiac imaging or cardiovascular imaging, but is important because this competence now we have in different area, also in neuroradiologics, for example, but in other different area, because in the last period, maybe we can say that we have in the AI era. So we need to understand the different devices, the different systems that in our reality, in our daily work, we just use together other professionals. So we need to understand the potential that have this device, this system, and to understand how is it possible to learn, to manage, and to use to serve our professional profile, but also the activity for the patients. And another important task for us about the collaboration is not only with specific professional, but it's only with a different professional around not only Europe, but also in other part of the world. And this is only an example because as we stay here today, with great pleasure for us, we have some collaboration and agreement also with the Brazilian technical technologists also, but we have had also the possibility to participate for the first time last year at the Asian Radiological Congress. So it's very important for us because we have a possibility to acquire different things, to acquire different picture about our profession, and maybe together, why not, to understand the best way for everyone about our profession. And also the possibility to collaborate with important event around Europe, and not only in this case, the possibility also to start with a very good exchange in Global Advances Practice Summit with Australian colleagues in the next month, also in the REM 2026 events, and a very great interesting collaboration with the EIA regarding the possibility to improve also specific program to support colleagues around Europe. And maybe very important task for us, as I said also Altino in the previous presentation, is the collaboration with the patients. In my personal experience, in my background in radiotherapy, is very important also to underline this task, because yes, we need to have also at the center of our activities, at the center of our profession, the patients, but maybe in the last period we also to understand how it's possible to include the patient not only at the center, but inside the circle, because we need to also understand the patient needs. We need to understand to collect other information, not only obviously very important evidence, scientific evidence that we need to understand the best way for the patients, but also to difference information. For example, the real world data direct from the patient with different devices. We have also in the digital era. So we have so different devices to use to include better the patients during the decision process, during the possibility to define the best way, the best treatment for the patients. So we need also to understand how it's possible to acquire this need, to acquire the patient voice, and to decide together in this important cycle with different professionals, and to include also the patients in our activity and decision. The second important task is the importance of the education, obviously, because it's possible to improve knowledge and skills between throughout the education, because it's the key to advance our professional role. And as I said, Altino, in our EFRS vision, is important to understand how it's possible to connect the clinical part and the research part, and to use the clinical experience and academic experience to define the best way to serve the patients and to serve also our profession to improve our activities and skills. skills for the next future. In this paper, we have 3 important statements specific for the important topic for us to improve the education, the research and practice. But in my idea, is very important to define another important pillar, that is the leadership, because it's important to guide the possibility to define the best way, and to guide also the possibility to understand how it's possible to have good strategy to work on also specific barriers that we have also around Europe, because you know that we have a different training program not only around Europe, so we need to understand how it's possible to harmonize our activities and also to have possibility to welcome the different culture and to understand the best way to work together, and also the difference of legislatures that we have in different countries. This is again, so only some information regarding the possibility that is possible to see the difference possibility to have program training around Europe, and not only. We are working to give also in different parts around Europe the bachelor degree as a first level for everyone for the training program. We are working on that, and we hope also in the next future to have these important results for everyone and so many countries around Europe, and not only. It's important this task also because it's important also to work to have a very good level of autonomy regarding our profile. This is a very important task for us because we know that yes, we need to increase our skill to push the possibility to improve our strategies, but we need also to harmonize for everyone in different countries our professional rule. So the third point is the importance of the technical innovation, that because we have step by step every day, every innovation, and to join the expertise. In our last experience in cardiac imaging event in Glasgow, in the last few months, we underlined also the importance to improve in this task, for example, our skills, because step by step the radiographers take an active role in managing data set, applying the segmentation and extracting clinical data. So we need to understand how it's possible to work together with radiologists, and not only, but also have a very strong expertise and knowledge regarding our possibility and technical skills, but not only, because it's important also to help the as best as possible to obtain also important and positive outcome from the patients. So is fundamental the collaborative approach, and also have the radiographers needs regular updates and advanced training to stay current with evolving technologies and clinical relevance. For this reason, we are working also on that. This is our delegate in a USOMI election, because we know that yes, it's important the AI, but around the AI is important also to define a specific training also to know better the activity that is possible to improve regarding the activities on rigs, PACs, and everything is important to know regarding the informatic imaging, and not only. So for this reason, we create in the last period a dedicated working group in the EFRS to understand this way, to define the new strategy, and as you read in this slide, also to define a dedicated scope and focus with this working group. And maybe in the next few months, we are happy with share also with all community and also with you a dedicated curricula to improve our knowledge and skills regarding this important task, also especially in AI. So the take-home message with you, maybe 3 important words that I will reflect with you today after this presentation: the importance of innovation, the collaboration, and evolving the rules, because the innovation needs collaboration, because we need to understand together the best way. The collaboration unlocks the evolving rule and evolving rules deliver better care. So I will conclude my presentation with an important phrase from Leonardo da Vinci, learn to see, realize that everything is connected. One most important word that we use during this event is connectivity. So it's important to connect and to know the different devices, the different system that's possible to use to connect some parts of our world, but our job, but we need also to understand by learning to see, we truly comprehended how everything is connected, but everyone can be connect to improve the network, to improve the collaboration, because together is always useful, is always better to work. Thank you so much.
Can you hear? Thank you, Dr. Patrizia Cornacchione, for your wonderful your opinion, the sharing to your presentation on the first time you come into the CPD. So thank you so much for Patrizia, Dr. Patrizia, and Mr. Altino. The first time come to this CPD and sharing wonderful is your reviewing and knowledge too about the EFRS, and we will know more about you, and hope that we will make the collaborate with you and with your association to in the future. So to the last but not least, please welcome the senior lecturers, associate professor Cung Cong. He's the deputy head of the Department of Diagnosis, Imaging, Universities of Medicine and Pharmacies, belonging to Vietnam at National University. Besides that, he's also an honorary academy of the scientific societies, both domestically and internationally. Outside, he's a committee of the Acute board of the Vietnam Society of Radiology and Nuclear Medicine. And now he's president of the Vietnam Society of Thoracic Radiology. And the title of his presentation is "The Role of AI in Supporting the Reading of Tuberculosis, CSR, Current Practice and Development Orientation of the Accelerate the Process of Ending Tuberculosis in Vietnam." So please welcome Dr. Cong.
Yeah, thank you, Mr. Duong. Hello, everybody. Hello, the president, some speaker, and our staff standing to hear me now. The first, I think the risk conference organized in Vietnam, and I think there are so much our staff, Vietnamese doctor standing here. So I think the translation to Vietnamese language is not good. So I would like to say that I talk my presentation by speak English, but some important information I would like to speak by Vietnamese English for our staff to understand. Because I think the TB is very, very important for medical doctor, Vietnamese medical doctor, to stop TB in the near future. My presentation is the roles of AI in supporting the reading of tuberculosis by chest X-ray, current practice and development orientation to accelerate the process of ending tuberculosis in Vietnam. As allows tuberculosis remains quite prevalent and continues to be a major disease burden for many countries around the world, including Vietnam. Vietnam currently ranks 11 among the 30 countries with the highest tuberculosis burden worldwide. The current strategy to end tuberculosis in Vietnam is to chastening, active case finding, which mean enhanced tuberculosis screening in community. Some about the AI, the possible sorting in reading the chest X-ray. As you know, artificial intelligence is brand of computer science. It is intelligence created by human program with the goal of the enabling computer to automatic intelligence behavior like human. Actually, AI can computer acquire the human intelligence such as the ability to think and reason, to solve problems, the ability to communicate by understanding language and speak, the ability to learn and adapt, etc. I'm sorry. AI technology created intelligent machine and system through the use of computer model, related techniques and technology to perform tasks that require human intelligence. Generally, it's very broad field of study and comprising element of physiology, computer science, and engineering. Some common examples of AI include cell driving car, automatic translation software, visual assistant on phone, and visual opponent in the modern mobile game. Up to now, the AI technology is divided into four main type, current, at the future, and even. Type 1 is the AI can react the technology, for example, playing chess, playing game, etc. Type 2 AI technology with limited memory, for example, automatic driving in medicine can automatic detection of lesion on chest X-ray. Type 3, this AI technology can learn and think for itself and like what it has learned to perform a space. Up to now, this problem currently is not possible. Type 2, self-aware. AI consists of behaving like human, has emotion and understand the emotion of other. Currently, it's not sure. I think the very, very afraid that if you AI can remember you after meet you, I think it's very, very difficult to very in the future. Now, AI technology in healthcare, as you see on screen, there are so much the AI that take part in the field of the medical, neuro, chest, breath, MSK, and other cardiac abdomen. Even so, the person AI can take in CT, in MR, in X-ray, in mammography, in ultrasound. Yeah, you can see the CT scan. Is the AI can take part in the so much the last the person in the evaluate to reach the quality of the CT scan image. And another thing that AI can diagnosis, can detection, can quantification is the regulation, the quality of the technician, and and regulate the image enhancement after the scan post processing. So the principle of AI in the field of diagnostic imaging, if below the neuron, if the neuron is have the dendrite and nuclear and acin, and the and the network of the neuron is there are so much the layer. It is the neuron first can first layer and hit the lower and output layer. If the information about the medical input the first layer, first layer, the AI the computer can identify the and classify. After that, inputs in the hidden layer. Hidden layer can show the identify the and structure of the image of the image. After that, AI can computer can resum and classify the two outputs layer. The principle of AI in the field of diagnostic imaging is the two periods. The first period is the machine learning. It's during the training phase. Neural network is the fifth 10 of 1,000, especially million of labor image or instant in order to learn how to classify them. You can see this picture. The first the period it's machine learning. It's the input the neural network can show the identify the some animals you see here. After that, it's the deep to move the deep learning work. It's a role of Bible of high layer in identify the details of the animal, and so that after that the top layer and resum and conclude to output the how many percent and identify the dog or the quack. Intelligent machine can work at reach 9 human. If you can see the deep learning, machine learning, intelligent here. On those, so we can three period, and after that the machine learning AI go to deep learning and network couple of the adapting itself to new data, and I think it's a period. It's very very important to AI to more intelligent in the future. How about the AI in the fields of assisting in reading X-ray image of pulmonary tuberculosis? As you know, the tuberculosis is the very on the very popular disease in so much country, especially in the lower country, lower income country, among them in Vietnam. I think the use AI for reading the chat X-ray in the screening TB is very very important for the many country, especially about the identify the TB lesion. Especially we especially medical environment. Next, radiologic for the training in the community. Before the 2020, breaking up in the case decision require country to hand TB case to fight through three stated screening population at risk as recommended by WHO. Jet X-ray is one of the critical technologies that can be used for this purpose. On the case to jet X-ray is increasing the available trained professionals who can correctly read the image remain challenging in many settings. In 2021, WHO recommended for the first time the use of computer aided detection software to interact the jet X-ray when screening and triggering for TB. recommendation was based on an analysis of the diagnostic accuracy data for 3 such software products available at the time. Cat for TB, VX, with title Dell come from Holland. Inside CHR V1 unit by India, and QHR also by India for detecting pulmonary TB in individuals at 50 years and older. Compare with human interaction, compare with radiologic with bacteriological confirmed as the reference standard. In the WHO have evaluation result of 3 AI software program CAT40B V6 inside CHIV1 QHR V2 with comparison of expert interaction RAM. And the result is you can see on the table about the sensitivity. It's I think it's very good, up 19%, but the specificity HP is very low. You can see the CD software specificity HP only 66%. Compare with the human reader, it's about the 30 and 63%. That means community-based scanning about the facility-based screening CAT40B HP only about the 79%. Compared with the human reader, only 36 to 63%. It's very low. After evaluation, the WHO recommendation about the using CAD software to reading TB X-ray is I think only the high sensibility at if we use the AI for the diagnose TBK is a very low percent. About the period of 2021 to 2025, since 2021, the number of CAD software product on the market has increased. Two guy country implement and ponder on the performance of this software product. In 2022, WHO made open call inviting manufacturers to submit their CAD software for independent evaluation by the technical officer group TAG on tuberculosis diagnostic and laboratory sampling. The assembly was included the independent variation platform set by the Foundation for Innovative New Diagnostic. That means the 5 in the level. 5 perform an analysis of the software product using the variation platform and the stand for X product. The TAG discussed the result using an in-person meeting held in the level on 22-23 January 2025. At that time, have the 1, 2, 3, 4, yeah. Okay, 1, 2, 3, 4,011 software to so much the country to send to submit to WHO for evaluate. you can see the answer table. AI for radiology made in by Russian Federation. AI shop, AI service also Russian. AI is rated by Russian Republic South Korea. Get for TB by New Zealand and then after that rugby set in South Africa. But of these 5 products, AI for radiology, AI service, AI series, AI 1.04 and later AI V1 .0.0 was excluded from analysis because they did not complete with the requirement of WHO recommendation. WHO can have the make the reason for excluded calculating because the software is have the SESP is very low, and next next radiographic, demographic, and next independent evaluation by WHO, and have a high the false positive threat, and next of evaluation for each group only. And for evaluate the 8 software ends, the WS, the TAC use 1,663 image for community-based screening, and on one library of 2,252 image for facility-based screening. As you know, the screening in facility in basic screening, I think it's have a different community-based screening from such study 7 based on the fixed 2-1 TBK, 2 long TBK was included. I think it's I think it's very, very important to evaluate because the TB ZXJ and mixed with the normal Israel read and sure that Patrizia shock study did not this was probability contribute to sensitivity and specificity performance estimate, and so you can see the table. The result after the TAC evaluate the software AI QXR and come from India. Inside CXR come from South Korea. Interference Dr. Chat V1011 from China. Dr. H from TV sending come from Vietnam. Zenki X come from America. Cat for TV V7 come from Hainan. Journal come from South Korea. And Rugby Chat come from Africa. So you can see the XR is I think it's over 50%, 50%. I think it's very good. But SP, you can see also a very, very low. 56%, 53%, 53, 59, 58, 48, 45, 41. Only rugby is very, very low. Only 26%. So you so you can see it's evaluated by the TB film have from community screening. And you can see the rock cube showing the performance of cat for TB. You can see the another color is the interface another software, but you can see the radiology here. Reading here. Okay. Also, I think the ECP of the some software is equivalent with the reading of radiology. So next step, on the AI field have evaluated by TB film screening at the healthcare activity. You can see the SESP here. I think it's the equivalent with community screening, and I think, but the SP is very, I think, have a regulation between to match data. This is accused of screening at healthcare activity evaluates. You can see that radiologist here about the radiologist sensitivity 90%. Radiologist sensitivity 50%. It's also the same compared with AI reading. So it's the interface of some software when make the result after reading to identify the TB lesion in the chest X-ray, Holland, South Africa, South Korea, Vietnam, South Korea, India, China, and America. I think it's very, very easy to identify the TB lesion, and by the head map and by cycle. I think the very I think it's the very friendly, very easy to identify when our doctor using this software for screening TB in the community. How to make this AI? As you know, to make this AI have so much condition for step by step. Step one is we have big data. After that, the labeling. After computer, and have a computer with convolution network, neural network CNN. After that, after labeling, we input the TB chat X-ray have a labeling to computer for machine learning, for deep learning. After that, we have the raw product and have to evaluate. After that, raw data evaluate finish. We have a raw product, and that means the research product from raw product and to component product. It's I think very long time and very to money to make the AI software commission product. How to make the big data? Standard chat X-ray. The first is we have a standard chat X-ray image for pulmonary tuberculosis patient. I think it's TB patient, and make the standard chat X-ray have to standard for MRS bio bacterial center. NAC quality. That cleaning data encryption. After that, data labeling, and The concept, the big data, is the answer. How about the labeling? We use the labeling follows plan by Stanford University of America. That is right, and we read and we confirm the low finding and have a medical device and have a lung opacity, and we divide the we recognize the edema, consolidation, numbness, and that is right can calibration fracture in the rib and the clavicle, and have pleural disease and perfusion pleural and pneumothorax. And also the Chinese, we see the cardiometastasis and cardiomegaly and widening metastasis, and you can see the from following the plan, you can see you can show the pneumonia come from consolidation lung and opacity lung, and pleural disease can other pleural. Yeah, no finding. Pleural effusion. I think to make the standard some characteristic for labeling. Pleural effusion isolation. Lung lesion, so much the load, edema, consolidation with bronchogram and arteriogram. So we use the tools for labeling for this with us just image about the FSP opacity, anatomy, coloration, pneumonia, okay, and edema, cavivation, favorite lung, cardiomegaly, following the plan of Stanford University. Now we are to do the study with Titan project KC 4.0 with purpose the research on binding a system to support the diagnosis and prediction of zooplaxal epidemic of pulmonary tuberculosis using jet X-ray image in Vietnam. Net dangerous immunity of the cell technology in Vietnam research the implementing unit at our hospital, Năng Alessandro Năng Triton. And we in our hospital we have the national tuberculosis control program accuracy time from 2019 and 2025, and we are finished. We are have a session about the February 2025. With the study have two purposes. Content one, we would like to develop a database of 3,000 labels that come chat is the image showing pulmonary tuberculosis distribution by age, by gender, by occupation and activity across about the 8 ecological regions in Vietnam. The second content is research and develop deep learning software, that means AI, to support the diagnosis pulmonary tuberculosis in Vietnam using chest X-ray image. You can see we are labeling, and this is the chest X-ray TB film. We use the 13 slides to labeling for this for every film. Infiltrate, small notes, large lot, lots with calcification, cavity, fibrosis, effusion, bilirubin, pneumothorax, bronchocystitis, thick lids, bilirubin, not calcification, thick lid bilirubin, have a calcification, have the last lympholag enlargement in hinder, lymphoid enlargement in mediastinum, and we show the lesion TB in the chest X-ray have in the hydron of the two lung and have two side and have two old lesion and new lesion in this runs of the TB lesion. Okay, you can see we are labeling, how to labeling. Yeah, also. So after that, we use we list the core technology. We use core technology in some CCN user respect, then select efficient net and VGG. It was so we do the two period FCLO, machine learning and deep learning. Machine learning the times concerning not number film standard labeling require the multi learning cycle. Multi learning cycle is very important to machine learning period. Require human machine interaction. After the machine learning, we do the deep learning, input the unlabeling image into machine. We machine learning, we put the labeling image, but deep learning we put the unlabeling image into the machine. The first CNN layer we identify identical detail. Yeah, you can see the first layer neural reference to identify CBO. I like the FX. The CNN layer will combine with detail into the complete image. Okay. The higher layer will not combine the image parts into complete image. The output will different identify, classify what the image is usually as the percentage. Yeah. That means the result of the deep learning and AI for answer is how many percent suspected about this image. You can see the 10% is the work, 19% is the log. The last step, AI software review, that means evaluate some method can we use evaluate the software. First one, growth of variation. Second, drops. Three, the comparison with the other method. That means the radiologist expert more rather than radiologist with CT scan and clinical physician. And at the end, the tech is the testing in the community and facility medical. That means interface for our software we make by KC for .1. You can see the rerun the answer the tuberculosis it's the percent suspected tuberculosis is about the 99%. That means in this case, they have the confirmed the TB case by MRS. Yeah. The second one, the second enable, you can see the on chest X-ray and have a lesion in the upper rows of the two lungs, and cavity and infiltrate and fibrosis, etc. And after that, the AI reading it, I think you can see the head map in the upper row and have the effusion pleural here. It's small, and this guy confirms the tuberculosis 100%. Okay. Conclusion. I think it's very, very important to when we when use the AI for reading TB chat X-ray. I think I make again the two table published by TAC after evaluate the H software TB reading the TB film and in community and faculty based screening. SE, I think the same. SP, I think the same, but very, very low. I think it's if you if the user only the chat X-ray film for confirm for diagnosis TBK when in the clinical every day, I think it's not need not good. If you only alone use the film, you without MRS, you will have among the 50% it's wrong diagnostic. I think it's very, very, it's not good, very, very dangerous for patient. If you confirm the TB case only by check film, it's very, 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 very not. Ở chỗ này thì tôi cũng xin phép nói bằng cái tiếng Việt để cho các bạn Việt Nam hiểu một chút. Sau khi mà nghiên cứu tất cả những cái đánh giá của Tổ chức Y tế Thế giới về các phần mềm AI hỗ trợ đọc phim đau phổi ấy, thì người ta mới thấy rằng là nó không hẳn là như trước kia người ta tưởng. Về độ nhạy, tức là khả năng mà phát hiện tổn thương thì thông thường các cái phần mềm đều đạt cái mức độ trên 90%, bảo cái 90%. Nhưng mà độ đặc hiệu, tức là cái khả năng chẩn đoán đúng bệnh nào của các phần mềm ấy, thì trên thực tế là thấp. Và ở đây thì các bạn nhìn đấy, kể cả đánh giá cộng đồng cũng đánh giá cơ sở y tế, các cái phim đánh giá cơ sở y tế, thì rõ ràng câu chuyện đặt ra là cái specificity, tức là cái độ đặc hiệu, tức là cái khả năng chẩn đoán đúng ấy, nó chỉ trên đến 50% thôi. Bởi vậy cho nên nếu các bạn mà dùng phim X quang thường quy đơn thuần để các bạn chẩn đoán nào ấy, sau đó các bạn điều trị cho người ta, thì vô hình dung các bạn đã có 50% là sai thiếu sai thừa rồi. Thì cái này là cái là tôi cũng muốn đưa ra cái lớp này, thì vì tôi biết là lớp này có rất nhiều các bạn Việt Nam ngồi đây. Vậy thì câu chuyện đặt ra là nếu các bạn mà trong quá trình thực hành lâm sàng các bạn không cần đến vi sinh, không cần đến giải phẫu bệnh, không cần đến lâm sàng, mà các bạn chỉ cần một cái phim để chẩn đoán và điều trị, thì điều ấy nó sẽ nguy hiểm như thế nào đấy. Và tôi biết rằng là bây giờ chương trình Chống Lao Việt Nam là có rất nhiều những cái phương tiện để mà xét nghiệm được vi khuẩn một cách rất chính xác, từ vấn đề là soi tươi đến làm expert, rồi đến nuôi cấy, đến giải trị tế gen vân vân, thì chúng ta làm được hết rồi. Bởi vậy cho nên là các bạn tôi nghĩ rằng là cộng đồng các cái ngành chuyên gia về phổi của mình ấy, thì cũng cần phải biết rất rõ cái thông tin này. Và trong cái phần này thì tôi đã trình bày các bạn rồi nhé, là người ta đều có so sánh với gọi là Radiologic, tức là những cái chuyên gia đọc. Thì thực ra ngay cả các chuyên gia đọc rất giỏi ấy, thì cũng chỉ đọc được đúng 50% thôi, chứ không hơn được. Đấy, các bạn nhìn vào mấy cái mà tôi đã đưa ra những cái phần mềm mà để cho các bạn thấy rằng là câu chuyện đặt ra là đây, tất cả Radiologic cũng đọc cũng nằm phần này thôi. Đây là ở cơ sở y tế đấy. Thế còn đây ở cơ sở ở sàng lọc cộng đồng đây, thì Radiologic có cái màu tím tím này, các bạn nhìn thì cũng nằm ở cái đường cong gốc này. Vậy là cái việc mà nếu như tin tưởng vào các cái chuyên gia mà gọi là có thể giỏi về đọc phim ấy, mà các bạn cũng cứ nghĩ rằng là nếu dùng cái đó để mà chẩn đoán ấy, để mà sau đấy mà điều trị. Thì tôi nghĩ là đến giai đoạn này là chúng ta phải hết sức lưu ý. Đấy, thì tôi cũng rất là muốn đưa ra cái thông điệp này để các bạn cũng nắm, và muốn hay không muốn thì cái tôi cũng đã thật với Nhập với Dũng là cái này thì lần này chúng ta tổ chức ở Việt Nam thì có lẽ là chúng ta cũng rút kinh nghiệm là như nào đấy, là các bạn Việt Nam nghe hiểu nhiều hơn. Chứ như hôm nay thì rõ ràng câu chuyện là tôi nghĩ là cái tiêu chí cũng chưa đạt. My presentation stop here. Thank you for the attention.
Thank you. Thank you so much. Yeah. Okay. Dr. Cong, you want to say something?
Yes.
Yeah. Yeah, please, Dr. Cong.
No, my presentation stop here. Okay.
Thank you. Thank you so much, Dr. Cong, for your sharings and your updating about AI software to diagnose tuberculosis. And last time he talked about the Vietnamese to you can use the AI software to diagnose the tuberculosis, but it's the sensitivity is 95% of the software, but the specificity just low. Yeah, just lower. So you careful with the AI. It's good. It support so much for diagnosis the tuberculosis, but we have to careful with this so yeah, because thank you so much for the good sharing and the good presentation of Dr. Cong, and also for the speaker today. Very excited presentation, excellent term today. We have we gain some more and a lot knowledge and insight from you. And again, thank you so much. Now we are going to the Q&A session. Firstly, I'd like to invite presidents, panelists, and so we can discussion and give a question to the speaker. So please, you can talk.
Okay, I have a simple question. Dung?
Yes, please.
Okay. The first, I'm saying the speaker, Dr. Anh and Professor Cong. Okay, you have a recommend for everybody. You have a long time experience use AI in lung and tuberculosis. Okay, I believe you recommend very important home message for everybody. Only sensitive, only 50%. Of course, we believe, and also have we the human, we are radiologists. Also, we use X-ray for diagnosis, tuberculosis, and treatment for patient. Okay, cannot. No.
Oh yes.
Yes. Okay, that like AI. Okay, but we also think about in AI can guide for you. For example, far from in center, the big city, you have many radiologists and doctor, but in far from center. Yes, okay, necessary guide for you. Okay, recommend for you. Okay, AI tuberculosis. Okay, Professor Dr. Cong.
Yeah.
Yes, I think everybody understand, and thank you so much for you share for everybody. And I have a question for Mr. Altino. I saw in your slide maybe in 13, you mentioned that our contribution are sometime limit by national law. From the EFRS experience. In Asia, we are also national laws very important. How how can professional society invest advocate to police markets to update laws, expand the scope to practice for radiographer, especially in the AI era. Altino, you hear me?
Yes.
Yes.
So can I reply? Thanks for the question. Do you want me to reply now or
Yep.
wait?
Yep, if possible, you can now.
Okay. Yeah, thank you for the question. In fact, we as professional society or as European stakeholder, we can't put ourselves into a position of discussing national legislation or national frameworks. What we can do as a stakeholder is to support our national societies, to support them, help them to develop the profession at national level. And how can we do that? We can do that by working on, let's say, general policies, on helping them by developing the scope of practice, the standards of practice, providing them with supported documents, with evidence-based practice, with good examples from other countries. But we can't just simply say to the national governments, you must. We can never use the must approach. So we just need to showcase how important we are, how developed we are now, because we are 30 years ago or 40 years ago, we were a young profession, but we have developed since then. We have lots of education and training, different education and training, different levels. We have advanced roles. We have a doctoral level, as Patrizia here today, and we have lots of radiographers with doctoral level. So we just need to showcase and to remind people, make people aware. When I say people, is governments, national institutions, regulators, and so on, that the profession has evolved and has developed, and we are now in conditions of to work in a different level that we worked 30 years ago. And that said, I think that the most important thing is, and not only for Europe, but for the world, we need to speak as one. We need to showcase that in Europe, Asia, North America, South America, Australia, Africa, we are now in a level that, okay, not everyone, but maybe a residual, but we are in a level that we can be given new tasks, new roles, and new possibilities to work together with radiologists, as I said, radiologists, radiation oncologists, medical physicists, and so on. And I think that in this AI era, and this will something that we can also discuss with our two other speakers rather than Patrizia, but I think that we can, as EFRS, discuss this, is that in the AI era, that everyone is being trained in the same tools, the same new tools at the same time. And given that we are now, as I said, in a different level of knowledge, skills, and competencies, shouldn't we be trained in the same, with the same framework, with the same format? And I'm not saying that responsibilities should be the same, but at least the trainings should be the same. We should be having radiographers or radiological technologists and radiology probably being trained in these new tools, with the same pace, with the same framework. Even if we know that ultimately the responsibilities will be different, but at least we will be working together, and we will be working together for the same patient, in the same hospital, in the same institution, in the same healthcare, and in the same world. So I think that this is something that is worth to discuss. And of course, EFRS has its own vision, and we believe that not everyone, as I said before, not everyone, but those who specialize themselves, those who work, those who develop themselves, those who reach specific level of knowledge, skills, and competencies should be able to have further responsibilities and further roles in the healthcare system.
Thank you, Altino. Thank you. Okay, good. I think the AI era we change. But I think Europe very good opportunity. You have a strong society, big group. I think that you usually you speak in English or Spanish together. Okay, I think it's very easy for Europe. Okay, I believe correct. The second question with India, Patrizia. I have a question for you, but today, I think how we collaboration curriculum develop. I propose a session on how university should handle AI for students. We should focus on AI integration in education. We upgrade curriculum to keep the student future-proof. Special ethical guideline for AI, use AI in school. And then my idea, now we have a Peachy Luna also, President Malaysia now, Mr. Sawar. He also in university. I hope in next time we have like when platform like online also we have discussed, we have share, we can share experience how we handle AI for students. In your from the EFRS, you invited some university in Europe. We also invited some university in Asia. Peachy Luna director and Mr. Sawar in Malaysia connect with you, and we have a platform. We have how we share many university about that. I think Patrizia, you can how about your idea?
Thank you for the question, because it's important to take this few times to underline this important task. I think it is a very good idea. We need to connect our possibility and try to search together the best way. Obviously, to have a platform of similar devices to connect around the world experience, but not only, maybe is a good way that is possible to improve, to work on that. Obviously, as you said, in many universities, we have a different reality, obviously, but also important possibility that just have improved in the training program. So maybe in the next future, and EFRS trying to work on that, it's important to create this connection. For this reason, we started with our working group dedicated for this task, not only to define a dedicated curricula for use the AI for our rule, but also to implement, to propose, and to create maybe a new way to collect not only around Europe the colleagues, but around the world. This is a very important aim, but is important also for us. We are trying to work on that, and if possible also to support you and to understand as is possible to collaborate also in this important task. Maybe we are happy to support, because it's maybe very important result for everyone in the next future. We use it in our daily work, the AI, and also similar data around the AI, so we needed to understand, to learn, and to use better to serve also not only the patient but also to facilitate specific process during our daily work. So it's very important. In the next pass, maybe we have had a similar platform for different tasks. For example, in my mind, especially for my background in radiotherapy, most important platform to collect the experience, for example, for incident learning in safety. So maybe this is a similar possibility to improve a dedicated platform, not only for to understand better the use of AI, but also to understand the possible issues that is possible to prevent, to learn better and to use better in the next future. So thank you for this proposal. I think it's a very good idea for the next future.
Thank you. Thank you, Patrizia. I want to hear with Peachy Luna and Professor Sagwar, and also India or some another president. Let's keep in touch, and we get more in platform for we discuss for students in school. I want to hear from Peachy Luna and Professor Shawar in Malaysia and India also, and Palestine also. Yeah, please.
Yes, thank you, President Taiwan Locke. So firstly, I'd like to say that the presentations of our esteemed guests from EFRS are very, very interesting. From a country like mine, Philippines, and from the academe, all of us here in the colleges and universities would always design our curricula considering internationalization, globalized, approach, as we would always have in mind that our country is one of the countries that share talents, very good talents to the world. So we're always interested with knowing how we standardize practice, make known of what is advanced, how far are Filipinos getting the trainings and the right skills that the world needs. Regards the collaboration, I'm very much interested, President Locke, to share whatever I can do to make sure that all the interesting parties and societies can get the knowledge and the updates from our collaborations.
Thank you, BG. How I invite in Professor Sawar.
Okay, thank you, Mr. Wanlock. So as a Malaysian academic in the radiography field, currently we are having the standard from the Malaysian Qualification Agency, or the MQA, and as well as the Malaysian Allied Health Professional Council, or MAHPC. And the new standard program standard for Allied Health just launched last week, actually. That is a new standard launched by the Ministry of Health, as well as the MAHPC and MQA, that most of the curriculum, for not only for radiography or medical imaging, but throughout the allied health, that we are embedded the AI technology or AI knowledge in the curriculum. So it will be started by 2027, that every colleges and university is compulsory to embed that the AI technology or AI knowledge in their curriculum. So now is in the transition period of using the previous syllabus and the new syllabus that has been proposed by the ministry. So the document just launched last week by our Director General of Health in Malaysia. So it's a very good idea as well, if we can connect to each other and maybe can share what is the component of the AI in the curriculum for the ASEAN, and as well as the European countries. Thank you.
Thank you, Professor Sawar. Okay. I want to hear from another president. How about AI for students in next time? My idea now, I have an idea. For example, in June 20, we have a Southeast Asia conference in Vietnam. We will have one session. I would like to invite Professor Sawa and Peachy Luna. You are chairman. You connecting with in Patrizia and Altino. Connect with in some university in Europe. We have one session. Discuss how we use AI for student ethical guideline for students. We share some university. We have one session or 2 hours or 3 hours to one session in Vietnam. Of course, you are on site, and we invited some university online also. We invite them online. You please, we keep in touch with Patrizia and Altino. Okay, you are chairman, Professor Sawar and Peachy Luna. You are chairman about that for session education AI session. Okay, yeah, correct. Now, okay, I want to hear more, Professor, President.
Thank you. Absolutely. It's a great proposal, and we are happy to support on that. So thank you so much for this new opportunity to share with you our experience and to collaborate together. Thank you so much.
Thank you, Patrizia. Now, MC continue, Mr. Dung continue. Thank you.
Yes, so thank you for your it's a good discussion, and in the future with the collaboration in universities, some of the many countries around here, and I hope that we will set forward this collaboration. And next that we which inform that we will have about Bostat for the Vietnamese participation, or just only Vietnamese participation will do the Bostat for get the certificate because for Vietnamese government, and it just so international guests it do not the boss that will on the screen now, and now we so
okay,
yes.
say goodbye everybody in foreigner first, and on the
yes, you can Vietnamese participation can look in the screen the QR podcast. And now we before coming to the end, we so thank you again for the president, panelists, speaker, and all of the participants from around the world who could join here with us, and to on your participate on your discussion to make the wonderful to this CPD. And now we back to the Peachy Luna for the handle seminar and for the interview next CPD.
All right. Thank you, Sir Lutri Duong, for your superb moderation of the session. Thank you to all our presidents who stayed here, to all our invited panelists. As we conclude today's program, we once again would like to say thank you to our esteemed speakers and guests. We have Dr. Cung An, Dr. Cung Van Cong. We have President Dr. Patrizia Cornacchione, and CEO Mr. Altino George Cunha. Your presence here underscores the importance of international cooperation in advancing radiology, education, and research. And your dedication continues to inspire progress in radiology, medical imaging, and across Asia and beyond. So we have to hear hope. We hope to hear more from you. So for now, looking ahead, CPD Asia February 2026, we are delighted to announce that our next CPD Asia program will take place in February 2026, proudly hosted in collaboration with the International Society of Radiographers and Radiologic Technologists, ISRRT. It is with great honor that we received the message from the Vice President of ISRT Asia Australasia, Madam Chek Kui, who warmly invites all of us to join the important program. And so we look forward to seeing you there for another round of learning and collaboration as ISRRT lead the 59th CPD Asia session come February 2026. So we shall save that date. So finally, again, we'd like to say thank you to everyone here, especially the VT Healthcare Vietnam. Big congratulations to the VART, to President Thai Van Loc, and to your CPD Organizing Committee. We also would like to say thank you to all our live audience, those who registered to participate with us, and above all, to everyone who always continues supporting CPD Asia. So again, I warmly invite you to join us for another CPD Asia next month. Once again, I am Peachy Luna. Thank you, VART. See you again all next month.
Thank you. Bye-bye. Peachy Luna
Thank
inviting the
you.
next
Thank you.
EFRS.
Bye bye.
Thank
See
you.
you.
Thank you. Bye bye. Thank you. Thank you. Thank you.
Thank you. Thank you, Locke.
Hello.
Hello.
And let me thanks to the
Bye,
organizing
sir.
committee of
Sir
CPD
Mohan.
68 for
Sir
this
Selva.
meticulously designed CPD.
Yes.
Sir Mohan.
Thank you. Goodbye. Goodbye. Thank you.
Bye.
Bye, sir.
Yeah.